Welcome, everyone. In preparation for the six-part course on transforming resistance with ISTDP, I'm pre-recording this lecture to introduce the seminar series. So we've got our friend the chameleon here, and I'm really introducing him to begin to get us to think about this parallel between sitting in the therapy room and there being resistance there with us in near sight, but we can't quite see it. We can't quite feel it. We can't quite grasp it. It's camouflaged. It's in front of us, but it's exerting an influence without us necessarily being able to wholly know how to work with this. So the whole topic of the seminar series is then going to be thinking about how we learn to identify, sense, uh, and work with resistance in the room, in the psychotherapy process, so we can start to transform the resistance into an effective, collaborative therapeutic process. The medical model then of mental health doesn't really apply when it comes to psychotherapy. We try to have these objectively defined treatment goals with the idea that there's a clear, defined pathology that we can target, and if we target it effectively, then the patient will start to see improvements. They're going to start to feel better. The treatment can be considered effective. But then if we look across the range of different talk therapies, which there are, and we know there are a vast number, there's different theories regarding what we do and why we do it in therapy and what's going to lead to change. There are different processes outlined and different mechanisms of change specified, which different talk therapies presume are going to lead to an effective outcome. Then, despite that, though, when we look across the effectiveness literature, even though psychotherapy more broadly is a pretty effective treatment compared to, say, many medical interventions, broadly speaking, we see, roughly a remission rate of 40% at best across single presenting complaints, single mental health diagnoses, when we look at the efficacy literature at best. So there's an awful lot of people here who are continuing to have different symptoms and continuing to struggle. And then if you even look a little bit more closely, the relapse rates are really quite high, alarmingly high. Many people, even if they respond to treatment, go on to experience further difficulties further down the line. So how do we start to understand what makes psychotherapy effective, given there are so many different theories on the different ingredients of change, but also what the factors are which potentially get in the way of treatment being effective or more effective and allowing us to optimize treatments for more people? This is where the concept of patient factors is one factor which is commonly looked at, and why by no means that the whole picture, and certainly it's a simplification to suggest that it's a starting point, and it's going to be the starting point at least for our discussion today. So the idea here being, and this really links back to early psychotherapy models of change, that the concept of patient's openness and ability to engage in a treatment process is a key predictor of the likely effectiveness of that intervention. And the concept of a patient resistance or patient factors which inhibit their ability to actually engage in the therapeutic process being offered, and the theory of change which the therapist is looking to promote, potentially as an obstacle or a moderating variable to improvements in psychotherapy. So Dr. Davenloo, in his development and articulation of the intensive short-term dynamic psychotherapy model, described what he called the spectrum of psychoneurotic disorders to describe what he called the more resistant category of patients. And broadly speaking, here you can see five categories on this continuum, with on the left-hand side, we see the low resistant patient. And as we move across the spectrum towards the right, we see gradually greater degrees of resistance, i.e., greater challenges we might expect with clients engaging them in the therapeutic process and ultimately being able to achieve a more effective outcome. So on the left side of the spectrum, we can see clients with more single symptom-based problems, and typically the impact of attachment trauma and adversity is, and the load of attachment trauma rather and adversity is less on the left side. And as you start to work across the spectrum and the concept of having greater degrees of resistance from more moderate to extreme resistance, then we start to see a greater burden of adversity or assumed adversity and assumed attachment trauma in the developmental trajectory. Typically, that trauma occurs later in the trajectory, the less resistant, and earlier in the developmental trajectory, the greater degree of resistance you see according to this theory. You'll see less symptoms on the left side with more symptom burden, more character disturbance, and greater load of complex emotions, including rage, guilt about rage, and grief as you move across the spectrum of psychoneurotic disorders. So in this sense, the load of resistance varies according to the patient, and we're wanting to better assess the nature of the resistance that a patient is potentially manifesting so we can shape the treatment accordingly, and so we can think about realistic expectations for the treatment course.